Hello and welcome. Today we're diving deep into a fascinating and complex eye condition, Phacoanaphylactic Uveitis. This relatively rare form of uveitis can have significant consequences if left untreated, so understanding it is crucial for both patients and healthcare professionals. Join us as we explore its causes, symptoms, diagnosis, and management. Phacoanaphylactic uveitis is an inflammatory reaction triggered by exposure to lens proteins after a disruption of the lens capsule. Think of it like this: the lens, normally sealed off from the immune system, is suddenly exposed following surgery, trauma, or even spontaneous lens rupture. The body then recognizes these lens proteins as foreign invaders, initiating an immune response against them. This immune response is the root cause of the inflammation we see in Phacoanaphylactic uveitis. Let's delve into the pathophysiology, the inner workings of this disease. When the lens capsule is breached, lens proteins leak into the eye. These proteins are recognized by the immune system's T cells and B cells. These cells become sensitized and trigger an inflammatory cascade. This cascade involves the release of inflammatory mediators like cytokines and antibodies, which then attack the remaining lens material and surrounding eye tissues. This attack results in the characteristic inflammation of the uvea, the middle layer of the eye, leading to pain, redness, and vision disturbances. Phacoanaphylactic uveitis is considered a relatively rare condition. Precise prevalence and incidence are difficult to determine due to variations in diagnostic criteria and reporting. However, it typically arises after cataract surgery, particularly if there's a complication such as posterior capsule rupture. It's important to note that while more common after surgery, it can also occur following traumatic eye injuries that penetrate the lens, or, very rarely, spontaneously. Now let's discuss the signs and symptoms. Patients with Phacoanaphylactic uveitis typically experience acute onset of pain, redness, and blurred vision in the affected eye. Light sensitivity or photophobia is also common. In severe cases, there might be significant inflammation in the anterior chamber of the eye, the space between the cornea and the iris. A key sign is the presence of granulomatous inflammation, which means the inflammation has a specific microscopic appearance, sometimes showing clumps of immune cells called granulomas. You might also see keratotic precipitates, inflammatory deposits on the back of the cornea. Diagnosing Phacoanaphylactic uveitis involves a thorough eye examination by an ophthalmologist. This includes assessing visual acuity, intraocular pressure, and examining the anterior and posterior segments of the eye with a slit lamp. The presence of anterior chamber cells and flare, signs of inflammation, are crucial indicators. Furthermore, a history of lens capsule disruption, either through surgery or trauma, is a key piece of information. While not always necessary, laboratory testing can help rule out other potential causes of uveitis, such as infections or systemic inflammatory conditions. In some cases, a lens aspiration or biopsy might be performed to confirm the presence of lens-specific antibodies. While Phacoanaphylactic uveitis isn't typically categorized into distinct types, its severity can vary widely. Some cases present with mild inflammation that responds quickly to treatment, while others can be more severe and chronic, requiring more aggressive management. The primary goal of treatment is to control the inflammation and prevent further damage to the eye. The cornerstone of treatment is topical corticosteroids, eye drops that reduce inflammation. In more severe cases, oral corticosteroids may be necessary. Cycloplegic agents, which dilate the pupil, can also help relieve pain and prevent complications such as posterior synechiae, where the iris sticks to the lens. In some instances, surgical removal of the remaining lens material may be required to eliminate the source of the inflammation. Immunosuppressive medications might be considered in chronic or recurrent cases where corticosteroids are not sufficient. Currently, there are no specific preventative measures to completely eliminate the risk of Phacoanaphylactic uveitis. However, meticulous surgical technique during cataract surgery can minimize the risk of posterior capsule rupture and lens material spillage. Prompt management of traumatic eye injuries can also help prevent lens capsule disruption and subsequent inflammation. The prognosis for Phacoanaphylactic uveitis is generally good with prompt and appropriate treatment. Most patients experience resolution of inflammation and improvement in vision. However, chronic or severe cases can lead to complications such as glaucoma, cataracts, or macular edema, which can permanently affect vision. Research continues to focus on better understanding the immune mechanisms involved in Phacoanaphylactic uveitis, aiming to develop more targeted therapies and prevent long-term complications. Studies are also exploring the potential of newer anti-inflammatory agents and surgical techniques to improve outcomes.